Welcome to the deep dive. Today we're tackling the anterior pituitary gland, the master conductor of our endocrine system.
That's right.
And what's fascinating, really, is how its disorders show up. They're often not classic endocrine signs, are they? They can be subtle, systemic.
Yeah, easily missed.
Absolutely. It controls those 5 big hormone pathways: ACTH, growth hormone, FSH/LH, prolactin, TSH. And any imbalance, excess, or deficiency, it just ripples outwards.
Okay.
So our mission today is to dig into 2 really complex cases. These really highlight how crucial a detailed patient history and review of systems are, because sometimes the diagnosis hangs on, like one single clue you might otherwise overlook.
All right, let's get into it then. We're starting with the most common type of functional pituitary tumor, the one involving prolactin, case A.
Okay, case A. We have a 32-year-old woman. She had regular periods her whole life until about 6 months back. Then she missed one that's secondary amenorrhea, and since then they've just been all over the place, really erratic. She is sexually active, but pregnancy tests have been negative. And the physical exam, this is key, right? Shows clear discharge from both breasts, galactorrhea.
Yeah.
But the absolute crucial bit of info, the thing that really makes this a deep dive puzzle, is hiding in her medication list. She's got mild hypertension.
Okay.
And she's taking Methyldopa, 250 milligrams, 3 times a day.
Ah, Methyldopa. Okay. So putting it together,
Yeah.
new irregular periods, this unexpected breast discharge, and specifically Methyldopa on the med list.
Exactly.
So before you jump to, MRIs or thinking surgery, you need the labs.
Yeah.
You got to get that biochemical picture first.
What do we need?
Definitely a serum pregnancy test first, always. Then thyroid tests, TSH, T4LH, and FSH levels, and critically, serum prolactin level.
Okay, serum prolactin. Now, this brings up something important in the language. If that prolactin comes back high, how do we know if it's just high prolactin versus an actual tumor, a prolactinoma? What's the difference we need to watch for?
That's a really essential distinction. Hyperprolactinemia just means your serum prolactin is elevated, full stop.
Right.
And that can happen for, well, tons of reasons. Some totally normal, physiological, some pathological. A prolactinoma, though, that's different. That's a specific tumor, a neoplasm, because you've got too many lactotroph cells making prolactin in the pituitary.
I honestly didn't realize just how many things besides a tumor could push prolactin levels up. I mean, beyond the obvious, like pregnancy or breastfeeding. What else are we screening for?
Oh, the list is surprisingly long. It basically boils down to anything messing with the hypothalamus signals down to the pituitary.
Okay.
Physiologically, yeah, pregnancy, breastfeeding, but even things like direct chest wall stimulation. Think nerve injury, sometimes even things like nipple rings, believe it or not.
Wow, really? Okay. What about actual diseases?
Sure. Diseases or, say, trauma impacting the pituitary stalk or the hypothalamus itself, head injury, surgery in that area, infiltrative diseases like sarcoidosis, you can all do it. Hypothyroidism is a huge one, and chronic conditions like CKD, chronic kidney disease, or renal failure.
Okay, but circling back to case A, the big trigger, the one that really stands out here, seems to be drugs. And Methyldopa, if I'm understanding this, it flags because it interferes with dopamine, right? Which is like the natural brake on prolactin.
Precisely. Dopamine is the main off switch for prolactin release from the pituitary. So any drug that blocks dopamine receptors or messes with dopamine.
Prolactin goes up.
Prolactin goes up, yeah. And that includes a lot of common meds. First and second gen antipsychotics, think haloperidol, risperidone, some anti-nausea drugs like metoclopramide, and, crucially for our patient, certain blood pressure meds like verapamil and, yes, her Methyldopa.
So the Methyldopa blocks the dopamine effect, prolactin surges. What's the chain reaction then? How does that lead to the missed periods and infertility?
It's quite an elegant but destructive mechanism for the reproductive system. That excess prolactin acts back on the hypothalamus, and it inhibits GnRH release, gonadotropin-releasing hormone.
Oh, okay.
And if you shut down GnRH, you shut down the whole cascade below it. LH and FSH levels drop. That's called hypogonadotropic hypogonadism.
Got it.
And that causes the irregular cycles, the infertility.
Yeah.
And long-term, in women, it leads to significant bone loss, osteoporosis.
And in men, same mechanism.
Exactly the same mechanism.
Yeah.
Lowers testosterone. So men get decreased libido, erectile dysfunction, and also osteoporosis over time.
That really clarifies the downstream effects.
Okay, so let's use the number, the actual prolactin level, to try and sort this out. Drug effect versus tumor, is there like a rough cutoff point?
Yes. There's a really useful diagnostic rule of thumb here. Normal random prolactin is generally somewhere between 5 and 30 nanograms per milliliter, roughly.
Right.
If your patient's level is over 200 ng/ml, That is highly suggestive of a prolactin-producing tumor, a lactotroph adenoma.
Right.
Those other causes drugs, hypothyroidism, stock effect, they rarely push prolactin much above 200. Maybe 100, 150 sometimes, but usually not over 200. If you see levels over, say, 1,000, you're almost certainly looking at a big tumor, a macroadenoma. But hang on, before we see that 200-plus level and immediately order an MRI thinking tumor, you mentioned another culprit that can fool us, the thyroid. The sources hammer this point. Never diagnose a prolactinoma without checking TSH first. Why is that so critical?
Oh, absolutely non-negotiable. Here's why. If someone has severe primary hypothyroidism, their thyroid gland has failed, their body is screaming for thyroid hormone.
Makes sense.
So the hypothalamus responds by pumping out massive amounts of TRH, thyrotropin-releasing hormone, trying to stimulate the pituitary.
Okay.
But that super high TRH doesn't just stimulate TSH release. It also causes the cells that make TSH, the thyrotropes, to actually swell up, to grow in number. It's called thyrotrope hyperplasia.
And that looks like a tumor on imaging.
It could look exactly like a pituitary neoplasm on an MRI. Plus, high TRH also weakly stimulates prolactin release. So you get a pituitary mass and high prolactin. Looks just like a prolactinoma.
What?
But if you just treat the underlying hypothyroidism, give them thyroid hormone replacement, the TRH drops, the hyperplasia resolves, the tumor vanishes on MRI, and the prolactin normalizes. You avoided unnecessary surgery or medication.
That level of detail, it really shows why these pituitary cases demand such careful workup. Okay, so case A highlights sorting out meds and gland failure from a true tumor. Case B, acromegaly, is a whole different beast, right? It's about insidious growth we often miss.
It really is. Case B is another 32-year-old, a teacher. She comes in with really non-specific things initially. Severe fatigue, about a 60-pound weight gain over the last 5 years, and her periods are becoming irregular, too. She says she doesn't feel rested when she wakes up. Her family's really concerned because she's developed really loud, progressive snoring. And testing confirms she has severe obstructive sleep apnea, OSA, with an AHI, that's the apnea-hypopnea index, over 30, which is quite severe.
Okay, this already sounds like a diagnostic challenge. Weight gain, fatigue, sleep apnea. Could be so many common things. What shifts the focus? What physical exam findings make us think, hang on, could this be chronic growth hormone excess from a somatotroph adenoma?
Yeah, you have to actively look for the subtle signs of soft tissue overgrowth. In her case, we see some mild facial hair growth, hirsutism, but critically, macroglossia, her tongue is enlarged.
Ah, the tongue. That explains the severe OSA.
Exactly. It's physically obstructing her airway. She also mentions her shoes feel tight, they don't sit well anymore. We can actually see soft tissue thickening on her heels. And she complains of hand-tingling paresthesias.
Suggesting carpal tunnel, maybe?
Suggesting new-onset carpal tunnel syndrome, exactly. And she says she can't wear rings that used to fit easily. Her fingers have gotten bigger.
And then there's the metabolic picture, which sounds pretty disrupted, too.
Definitely. Chronic growth hormone excess wreaks havoc metabolically. She has early morning headaches, sometimes some breast discharge like the first case, and her labs are concerning. Fasting glucose is 145, HbA1c is 6.7%, that's diabetic range, and her LDL cholesterol is way up at 182. It points to a long-standing high-volume hormonal problem. Right. And another difference from prolactinomas, which, especially in reproductive age women, are often small, microadenomas, less than a centimeter. These GH-secreting tumors, the somatotroph adenomas, they're usually macroadenomas, bigger than 1 centimeter by the time we finally catch them.
That size implies it's been growing for a long time.
Yeah.
Why the huge delay? What makes this diagnosis so frequently missed?
It's primarily because the changes are just so slow, so insidious. You won't believe this, but the average diagnostic delay reported is 12 years.
12 years, that's staggering.
It is. Half a working life potentially spent with this progressing. And that delay isn't benign. It carries a huge mortality risk. Untreated acromegaly significantly increases death rates, mainly from cardiovascular disease. Think severe hypertension, often with left ventricular hypertrophy and enlarged heart muscle. Cardiomyopathy, heart failure, arrhythmias. It puts immense strain on the heart over time.
12 years of that, okay. So diagnosing it, you said random GH levels fluctuate too much to be useful. How do we nail this diagnosis down?
Right, you can't just draw a random GH level. It's all over the place. The pathway has 2 key steps. First, you measure serum insulin growth factor 1, IGF-1.
Why IGF-1?
Because GH stimulates the liver to produce IGF-1, and IGF-1 levels are much more stable throughout the day. It acts as a reliable proxy, kind of like a messenger, reflecting the average GH activity over time.
Okay, so IGF-1 first. Then what?
Then you need the gold standard confirmation, the growth hormone suppression test, using an oral glucose tolerance test, the OGTT.
Okay, walk us through that. What does drinking the glucose do in this test?
We're essentially testing the body's normal feedback loop, the braking system for GH. In a healthy person, if you give them a big load of glucose, typically 75 grams orally, it signals the body energy stores are full, and growth hormone production should shut down. It gets suppressed.
Right.
So you measure GH right before they drink the glucose, and then usually 2 hours afterwards. If that GH level is still above 1 nanogram per milliliter after the glucose load.
It means the tumor isn't listening to the signal.
Exactly. The somatotroph adenoma is autonomously pumping out GH, ignoring the body's command to stop. Diagnosis confirmed.
That's a clear pathway. So, pulling it all together for the clinician listening, what's the constellation of symptoms, maybe seemingly unrelated things that should scream, think acromegaly, screen this patient?
Yeah, it's about recognizing the pattern. The source materials really emphasize looking for this combination. New or worsening, often severe, obstructive sleep apnea, diabetes that's hard to control, new onset carpal tunnel syndrome, heart failure, especially if it's paired with significant hypertension. And this one's important, unexplained colon polyps found on colonoscopy.
Colon polyps, why are they on the list? That seems a bit random.
It's because growth hormone and IGF-1 are fundamentally growth factors. They promote cell growth and proliferation everywhere.
Ah, I see.
And that includes the cells lining the colon. So excessive GH-IGF-1 drives excessive growth there, leading to polyps and a significantly increased risk of colon cancer down the line. It's a key systemic sign that growth factors are running rampant.
That makes sense. A really important connection. Okay, so diagnosis confirmed, usually macroadenoma. What's the main treatment approach?
For almost everyone, the primary treatment is surgery, specifically transsphenoidal surgery going through the nose to reach the pituitary.
And how effective is that?
For smaller tumors, the cure rates are actually very high, like 80 to 90%. It gets trickier with very large or invasive tumors.
Okay. What if surgery doesn't get it all or isn't an option?
Then we move to medical therapy. There's several options. Somatostatin analogs, which mimic the body's natural GH inhibitors. Cabergoline, the dopamine agonist we mentioned for prolactinomas, sometimes works here too. Or pegvisomant, which blocks GH at its receptor. These are used if surgery fails, or sometimes before surgery to help shrink a large tumor.
Wow. This has been quite a journey through two really different, challenging pituitary scenarios. Case A, teasing apart prolactin causes dopamine, drugs, thyroid. And then case B, this incredibly insidious slow-motion disaster of acromegaly with that shocking 12-year delay. It really drives home how vital that deep dive into the patient's entire story, the full review of systems, truly is.
It absolutely is. And maybe one last bit of pituitary wisdom to keep in mind. Remember that paradox about damage to the connection between the hypothalamus and the stalk or the portal blood vessels?
Right. What happens then?
Typically, that kind of damage increases prolactin because you lose that constant dopamine inhibition coming down from the hypothalamus. But at the same time, it usually decreases the release of all the other anterior pituitary hormones because the stimulating signals can't get through.
Increases one, decreases the rest.
Okay.
That's a tricky but important point.
Yeah. Now, maybe a final thought for you, for everyone listening, to sort of mull over.
Okay.
The source material points out something quite poignant about acromegaly. Often, the patient themselves doesn't notice the slow physical changes, the face softening, hands and feet growing. It's too gradual.
Right, you adapt day by day.
Exactly. It's often the family, maybe looking back at old photos or noticing they keep needing bigger shoes or rings don't fit. They are the ones who sense something's changing over years. So if you know someone, maybe a friend or family member, who just seems to be gradually getting bigger over many, many years, not just weight, but features, hands, feet, and maybe they can't wear their old wedding ring or their favorite shoes anymore, maybe think outside the usual boxes. Think about hormones.